Welcome to Nursing Simplified, the smart way to survive nursing school. Welcome, nurses and future nurses. Today, we're talking about schizophrenia, a complex mental disorder that you will encounter in various clinical settings, psychiatric units, emergency departments, and even primary care. Let's dive into what schizophrenia is, how it presents, and most importantly, what you can do as a nurse. Oh, and keep watching for a huge announcement later in the video. The word schizophrenia literally translates to split mind. However, it's not the same as what you might be familiar with as multiple personality disorder or DID, dissociative identity disorder. Instead, it is about the separation of function between personality, thinking, memory, and perception. Schizophrenia can be devastating. It's a chronic brain disorder affecting around 1% of the population. The onset of symptoms is usually in the late teens or 20s. It affects more males than females, and females are usually affected a bit later. We're talking about the late 20s for females. It primarily disrupts a person's thought processes, emotions, and perceptions of reality. Schizophrenia also likely stems from a blend of inherited genetic predispositions as well as significant non genetic influence. Keep watching for a deeper dive into the pathophysiology. First, let's talk about the genetics. Schizophrenia or schizophrenia related symptoms appear in roughly 10% of siblings of individuals diagnosed with schizophrenia. Children with one parent who has schizophrenia has a 5 to 6% likelihood of developing the disorder, while having two parents with schizophrenia raises the risk to approximately 46%. There's also been research involving fraternal and identical twins, and that further suggests a substantial genetic component, with about 46% of identical twins and 14% of fraternal twins at risk for schizophrenia. Non genetic factors include viral infections, birth complications, poor nutrition, or even head injuries early in life. These can affect the genes responsible for brain function or cause direct damage to the brain. And over time, these factors can alter brain structures, disturb neurotransmitter systems, and disrupt neural circuits, ultimately leading to impairments in cognitive functioning. More on that later. As nurses, understanding these disruptions helps us provide compassionate care, early intervention, and reduced stigma. Schizophrenia spectrum disorders are a group of mental health disorders that have symptoms of psychosis. Psychosis is when someone loses touch with reality. It's like the brain is mixing up what's real and what's not. Think of the brain like a radio. When a radio is on the wrong frequency, it picks up distorted, scrambled signals. And these mixed up signals are sent to the brain, but the brain can't make sense of them. And that is psychosis. One thing to remember is that psychosis is a symptom, not a diagnosis. And we'll delve into some of the other disorders that fall under this spectrum in a future video. And speaking of future videos, make sure to like, subscribe, and share this video so other people just like you can find my content. I would positively appreciate it. Speaking of positive, often we think of positive things as something good. And when we think of negative things, we think of something bad. This isn't the case when we're referring to schizophrenia. The symptoms of schizophrenia fall into two main categories: positive and negative. And as nurses, you'll assess these carefully to help guide care plans and interventions. Positive symptoms are when we are adding something that should not be there, and negative symptoms are taking away something that should be there. Let me give you some examples. Let's start with positive symptoms. Hallucinations are an example of positive symptoms. These are commonly auditory, but they can affect any of the senses. The patient hears voices, or sees, feels, smells, or even tastes things that aren't there, meaning there is nothing in the environment that would cause the hallucination. A nursing tip here would just be to never discount the experience. Use therapeutic communication, saying something like, I understand you're hearing voices. That must be scary. I do have a warning here. You absolutely must assess for command hallucinations. For example, voices telling the person to harm themselves or someone else. And if present, ask the patient some direct questions, such as, do you plan to follow the command? Do you believe the voices are real? And do you recognize the voices? By being direct and asking these questions, you can determine if the patient is a risk to themselves or others. Another example of a positive symptom is delusions. Delusions are fixed false beliefs that cannot be changed by a rational explanation. For example, someone stating the FBI is after me when there's no reason for the FBI to be after them and it's not a fact. And some common delusions include the following: thought broadcasting. This is the belief that the individual's thoughts can be heard by others. Thought insertion is the belief that the thoughts of other people are being placed or inserted into the mind of the individual. Thought withdrawal is the belief that one's thoughts have been removed by the individual's mind by another person or entity. The delusion of being controlled is the belief that the individual's mind or body is being controlled by an outside person or entity. Delusion of grandeur is where the individual believes that they are very powerful or important, perhaps even having special abilities when none of these really exist. Delusion of persecution is the false belief that another person or entity is conspiring against the individual. Erotomania is the false belief that another person, who is usually a stranger, like a famous individual, is in love with the person. Somatic delusions are false beliefs that the individual is ill, even though they've had extensive testing that proves otherwise. Sometimes they even think along the lines of the extreme, such as that their heart is no longer beating or that their organs are rotting away. An extreme version of this are nihilistic delusions. And this is when an individual might deny their own existence and actually believe that he or she is actually not alive. The big nursing tip here: don't confront or reinforce the delusion. Simply respond with reality orientation and empathy. Disorganized speech is another class of positive symptoms. Things like rapid topic shifts, nonsensical phrases, and more. Some examples of disorganized speech are neologisms, are where an individual uses made up words. These words may hold some meaning to the individual, but sound absolutely nonsensical to other people. Echolalia is repeating another's words by imitation. This is often seen in patients with catatonia, where a person remains in a fixed position for an extended period of time. Fun fact, this is actually closely related to echopraxia, where a patient mimics another's movements. Clang association is meaningless rhyming of words strung together that don't convey an actual message. And word salad is a jumble of words that don't make sense. Think of putting a whole bunch of pieces of paper with different words on them into a salad bowl and mixing them up, and then pulling out random pieces of paper and creating a sentence out of those words. It's meaningless to others and often the speaker as well. The nursing tip here is just to maintain a calm environment and use short, clear statements. And now let's talk about negative symptoms. With these, there's a piece missing. Something has been taken away that should be there, and it's usually related to personality. And we can remember negative symptoms by thinking about the 6 A's. These include anhedonia, affect, anergia, alogia, apathy, and avolition. Let's go through each one. Anhedonia is the lack of ability to find enjoyment in things that were once enjoyable. These individuals tend to also isolate themselves and become quite withdrawn. The next A is for affect. A lack of facial expressions or range of motions is something we call a blunted or flat affect. Imagine trying to maintain relationships with others with a limited range of emotions and expressions. Anergia is a lack of energy. Those with schizophrenia can feel exhausted all the time. Imagine trying to hold a job when all you can think about is the next time you can sleep. Alogia means lack of speech. So basically, a decrease in quantity or content of speaking. Apathy is a lack of emotion related to other people, things, or activities. It is a state of indifference. And lastly is avolition. This is a lack of motivation, drive, and initiative. It makes it difficult to start or complete tasks. Even everyday activities like getting dressed or performing tasks around the house. It's not about disliking these tasks. Rather, the person simply can't muster up the motivation to either begin the task or finish the task once started. That internal spark has dimmed or gone out completely. And this often manifests as poor self care and hygiene issues as well. A nursing tip for this is just to provide gentle encouragement, break tasks into manageable steps, and praise small achievements. Now that we have discussed positive and negative symptoms, let's talk about the last group of symptoms that are present in schizophrenia, which are the neurocognitive type symptoms. Cognitive impairment is often considered a core feature of schizophrenia, affecting many domains of thinking and information processing. While positive symptoms like delusions and hallucinations and negative symptoms like apathy, lack of emotion may be more visible, cognitive defects are highly impactful on a day to day functioning basis and they affect long term outcomes. Below are some key neurocognitive domains commonly affected in schizophrenia. Attention and vigilance. This is difficulty sustaining attention over time, which would be impaired vigilance, as well as trouble screening out irrelevant stimuli, which would be considered distractibility. Processing speed. This is a slower ability to perceive, process, and respond to information. And this slowdown can affect everything from basic tasks to more complex decision making. Working memory. Challenges holding and manipulating information in the mind. For example, remembering a phone number while dialing. This can manifest as forgetting instructions or difficulty completing multi step tasks. Executive function. This is related to difficulty with planning, organizing, and problem solving. There's reduced cognitive flexibility, which is, for example, trouble shifting strategies or maybe even adapting to new rules. There's also poor abstract thinking. For example, a patient might interpret metaphors literally or struggle with hypothetical scenarios. Verbal and learning memory has to do with a reduced ability to encode new information and then recall it later. This may be apparent in trouble remembering conversations or learning new skills. Language and communication. There are often subtle language deficits that can include difficulty finding words or expressing complex ideas coherently. Speech, as we've discussed before, can become very disorganized in some cases. And social cognition. This is difficulty perceiving and interpreting social cues, facial expressions, and the intentions or emotions of others. And this contributes to problems with social interactions as well as relationships. Wow, that's a lot so far. Let's take a quick break to talk about our sponsor, me. Did you know that Nursing Simplified is going full time in May? That's right. That means more frequent videos for you. I'm also trying to build the best nursing community on YouTube. So each month, the individual with the most interactions in the comments will be selected to win a prize. And the more videos you comment on, the more likely you are to win. Each month, a winner will be announced, and you will be directed to contact me so I can send your gift. Gifts are always a surprise. They could be a small token of appreciation, or merch, or something bigger that might help you in your career. And by the way, did you know that you can find me on Facebook, Instagram, and that I also have a website where you can download free cheat sheets, get current discounts for services and merchandise, and a whole lot more. All the information is down in the description box. So start commenting, visiting me on other platforms, and just getting involved in this great community. I look forward to seeing you in the comments. Okay, let's move on. There are four phases of schizophrenia. First is the prodromal phase. This is the phase that happens prior to psychosis. Symptoms are less severe, and early treatment in this phase may actually help prevent full blown psychosis, and it could help diminish chronic symptoms. Next is the acute phase, where those positive, negative, and cognitive symptoms are more fully developed. It may become more noticeable to others that the individual is acting differently or even bizarrely, and hospitalization is sometimes necessary during this phase. The stabilization phase is where the acute symptoms begin to decrease in severity, especially with treatment. And then there is the maintenance phase where symptoms are in remission, even if there are some mild residual symptoms. It is important to note that due to the chronic nature of this disorder, that these phases can become a cycle. According to the DSM-5, it is extremely rare for an individual with schizophrenia to recover, and that only about 20% have a favorable outcome. The signs and symptoms of schizophrenia are so much more numerous than presented here, and not all symptoms apply to all individuals with schizophrenia. Each person with schizophrenia is a unique individual, although he or she may share common symptoms with others. The Diagnostic and Statistical Manual of Mental Illnesses, otherwise known as the DSM 5, is the American Psychiatric Association's professional reference book on mental health and brain related conditions. It's not a replacement for help from a medical professional. Instead, the DSM 5 uses a classification system that provides standardized criteria, terminology, and guidelines for diagnosing various conditions. Let me give you an example. There are certain criteria that need to be met to be diagnosed with schizophrenia. An individual must meet criteria in three categories. The first category, or criterion A, is related to the characteristic symptoms. The individual must experience two or more of the following symptoms for a significant portion of time during a 1 month period. And at least one of these symptoms must be delusions, hallucinations, or disorganized speech. The other two symptoms that are associated with the criterion A are grossly disorganized or catatonic behavior, and some negative symptoms like the reduced emotional expression and lack of motivation. Criterion B is related to social and occupational dysfunction. For a significant portion of the time since the onset of the disturbance, the individual's level of functioning, for example, in work or relationships or self care, is markedly below what it was prior to the onset. Criterion C has to do with the duration. So, the continuous signs of disturbance have to persist for at least 6 months. And then that 6 month period must include at least 1 month of the active phase symptoms. Those are the ones that we spoke about in criterion A. And the remaining time may include prodromal or residual symptoms, which may be milder forms of the criterion A symptoms or primarily negative symptoms. And lastly, there are a number of things that need to be ruled out. So we have to rule out all of the below. The first thing is we need to know that this is not a schizoaffective or mood disorder. They can have psychotic features and mimic schizophrenia, but they're a completely different disorder. There can't be substance or a medical condition that would explain these physiological effects that would manifest in these symptoms. And also, we have to rule out the fact that perhaps these symptoms are related to autism spectrum or communication disorders. So, if there's a history of autism spectrum disorder or communication disorder of childhood onset, an additional diagnosis of schizophrenia is made only if prominent delusions or hallucinations are also present for at least 1 month. So, how do we treat schizophrenia? Well, we use a multifactorial approach, but from a pharmacology standpoint, we use antipsychotic medications. Let's talk about the relevant pathophysiology in psychosis using the dopamine hypothesis. And the key concept here is that there's excessive dopamine activity in certain brain regions, particularly the mesolimbic pathway. This is thought to contribute to the positive symptoms of psychosis, like delusions and hallucinations. Negative and cognitive symptoms are likely linked to dopamine dysregulation in the mesocortical pathway, among other complex factors like neurotransmitters such as serotonin and glutamate. But what are these pathways in the brain? Well, we have dopamine pathways in the brain. The first being the mesocortical. And this is associated with cognition and executive function. Underactivity may lead to negative symptoms like flat affect, social withdrawal, and cognitive deficits. The next one is the mesolimbic, and this is associated with reward, motivation, and can cause positive symptoms when overly active. The tuberoinfundibular pathway regulates prolactin release. Dopamine blockade can actually increase prolactin and lead to endocrine issues such as galactorrhea, which is the production of breast milk that is not associated with lactation. The final pathway that we discuss is the nigrostriatal. This coordinates movement, and dopamine blockade here can cause extrapyramidal symptoms or EPS, which we are going to get into. We have two types of antipsychotic medication. We have typical antipsychotics, also known as first generation antipsychotics, and we have atypical antipsychotics, also known as second generation antipsychotics. Let's compare the two. Some examples of first generation antipsychotics are haloperidol and fluphenazine. These are high potency first generation antipsychotics. We also have chlorpromazine and thioridazine. Those are considered to be low potency antipsychotics. These drugs primarily work by blocking dopamine receptors in that mesolimbic pathway. This reduces positive symptoms like hallucinations and delusions. However, strong blockade can cause extrapyramidal symptoms, and more on that to come. There are considerable side effects. In addition to extrapyramidal symptoms, there are anticholinergic effects, especially with the low potency agents. This can cause sedation, dry mouth, blurred vision, and constipation. Orthostatic hypotension due to alpha 1 adrenergic blockade is also common with low potency agents. And then neuroleptic malignant syndrome. This is rare but potentially fatal, and more on that to come. Now, on to our second generation antipsychotics. Some examples of these are risperidone, olanzapine, quetiapine, aripiprazole, and clozapine. They still target dopamine, but often with less intense blockade compared to typical antipsychotics. They also use some serotonin antagonism, and that helps modulate dopamine release in other pathways. This can improve negative symptoms and reduce the risk for EPS. The side effects are generally a lower risk of EPS compared to typical antipsychotics. The risk of EPS is lower compared to typical antipsychotics. However, there are metabolic effects such as weight gain, dyslipidemia, and increased risk of type 2 diabetes. Sedation is common, prolactin elevation can still occur, and agranulocytosis, especially with clozapine. These patients will require regular white blood cell count monitoring due to the risk of severe neutropenia. And here's an easy to remember chart comparing typical or first generation antipsychotics and atypical or second generation antipsychotics. Hopefully, this will help you remember what some of the symptoms are, how they work, and just give you a better overall knowledge. I would recommend taking a screenshot of this chart so you have it to study from. So, what are these extrapyramidal side effects or EPS? Well, let's talk about it. One known side effect is pseudo-Parkinsonism, and this is where the patient displays symptoms that are similar to Parkinson's disease, such as stiffness, stooped posture, and shuffling gait. Acute dystonic reactions are spasms. They typically begin with the tongue and jaw and can move to the face, neck, and even the back. This can progress to opisthotonos, which are spasms of the entire body, and also oculogyric crisis, where the eyes lock in an upward position. Akathisia is an inner driven restlessness that can result in constant, uncontrollable motion, like foot tapping or rocking back and forth. It can be extraordinarily uncomfortable for the individual. Tardive dyskinesia usually stems from prolonged treatment. It can range from mild to incapacitating. Symptoms include protruding and rolling tongue, smacking movements of the face and mouth, purposeless movement, and jerking of the limbs and trunk. Frequently screening with the Ames test can help detect tardive dyskinesia in its early stages. However, once it develops, the side effects can remain permanent. Extrapyramidal symptoms can be treated using a variety of approaches aimed at relieving its symptoms. So, medications like anticholinergics, dopamine agonists, and antihistamines may be used to reduce movement disorders and muscle rigidity. In addition, physical, occupational, and speech therapy can support improvements in motor function and communication skills. The most severe complication of antipsychotic use would be neuroleptic malignant syndrome, or NMS, which is a rare yet potentially fatal adverse effect that typically begins in the first week or so of therapy, but it may occur later. The symptoms include severe extrapyramidal side effects, hyperpyrexia, a temperature over 103 degrees Fahrenheit or 41 degrees Celsius, and autonomic dysfunction, which just means dysfunction of all the things our body usually manages without our control. This can include severe hypertension, tachycardia, diaphoresis, incontinence, and changes in levels of consciousness, ranging from confusion to seizures to death. In addition to pharmacological therapies, psychotherapy, cognitive behavioral therapy, social skills training, and assertive community treatment are all part of the individualized treatment plan. Assertive community treatment is an intensive outpatient approach. It's been found to reduce hospitalizations by emphasizing the patient's strength and providing support in nearly all aspects of life, such as food, shelter, school, grooming, transportation, and budgeting. It can also encompass mobile crisis intervention and substance abuse treatment if needed. It is a multidisciplinary team approach with a member of the team available around the clock. As you enter clinical practice, you will play a critical role in managing schizophrenia through assessment, patient education, medication monitoring, and support for both patients and families. Always remember to approach care with empathy, professionalism, and a holistic mindset, treating not just the symptoms, but the whole person. I hope you now feel more prepared and confident to care for patients with schizophrenia. If you liked this video or you learned something, please like, subscribe, share, and don't forget to comment to be in the running for a surprise gift from me. As always, keep asking questions, seek guidance from your preceptors, and stay curious. And until next time, remember, nursing is a work of heart. See you in the next video. Bye bye.